Good afternoon to all the faculties and students. Today, our topic is pathology and clinical features of COVID-19 virus. What you see here on the top right corner is the Wuhan seafood market. On December 2019, several unusual cases of pneumonia were noticed in the hospitals in Wuhan. On 7th of January 2020, the Chinese health authorities confirmed a cluster of cases of pneumonia. On 11th of January, China records its first COVID death. On 13th of January, the first corona case outside of China was detected in Thailand. The reproductive number of COVID-19 virus is 2.2, and its incubation period is 2 to 14 days. And finally, on 11th of March 2020, the World Health Organization declared COVID-19 as a pandemic. The world is now in a pandemic, and the World Health Organization has urged countries all over the world to take necessary measures to control the coronavirus. Coming to our topic, the COVID-19 virus, it infects the lungs, causing a characteristic ground glass opacity. And there are several researchers which suggest that the COVID virus, apart from the lung, also infect the stomach, liver, and the kidneys. In addition to it, it causes a cytokine storm, which leads to the inhibition of the body's cellular immune response, leading to decreased in lymphocytes and platelet count. Now, before we understand the pathology and clinical features, it is important that we understand the pathogenesis of the COVID virus in order to get a proper base. I'd also like to add that all the following diagrams were drawn by us and not taken from the internet and then animated. So COVID virus, as we know, it enters the lungs, it gets into the alveoli. The alveoli is lined by two types of cells, the type 2 cells and the type 1 cells. The type 2 cells are responsible for producing the surfactants, and it is the type 2 cells which express the ACE2 receptors, as you can see here, to which the coronavirus comes and binds. After binding, it enters the cell via endocytosis or via direct fusion with the host membrane, like this, after which it undergoes uncoating to produce a positive sense single-stranded RNA, which is fed by the host ribosome to produce a protein, which produces an RNA polymerase. This RNA polymerase reads the positive sense single-stranded RNA to produce a negative sense single-stranded RNA, which is again read by the RNA polymerase to produce not one, but many positive sense single-stranded RNA, and these are taken to the endoplasmic reticulum, which is read by the ribosomes in the endoplasmic reticulum for what? In order to help them make the structural components of the virus, after which it is transferred to the Golgi apparatus along with the positive sense single-stranded RNA to produce many coronaviruses, which exits the cell via endocytosis. And these COVID viruses goes and infects other cells. Now, what is the significance of saying all this? It is nothing but the viral replication in the alveolar cells initiates the inflammatory response. Having said this, let us try to explain the clinical features associated with the COVID-19. And what is the most common clinical features that we hear? It is the dry cough. So the injured alveolar cells, they release the interferons, cytokines, DAMP. The DAMP goes and is detected by the alveolar macrophages, which lead to the release of several cytokines and tumor necrosis factors and interleukins. Now you can see a series of inflammatory response that is happening here. And all of these series of inflammatory response, it stimulates the nerve endings, and that leads to dry cough. The next is fever. The prostaglandins, the tumor necrosis factor 1 and interleukin-6 causes fever here. The next one is dyspnea and hypoxia. So the tumor necrosis factor 1, the tumor necrosis factor alpha, the interleukin-1, all of this lead to an increase in vascular permeability, and the adhesion molecule, which are present on the sides of the vascular vessels, their expression is also increased. Now that lead to increased recruitment of neutrophils and monocytes. Now all of this, it leads to leakage of fluid into the interstitium and alveoli, which causes interstitial and pulmonary edema. That is the first reason. The second one is the surfactant production is reduced. When the because type 2 alveolar cells are infected, of course. The next one is in leukotrienes, which causes bronchoconstriction. So 3-4 factors here. All of this lead to dyspnea and hypoxia. And this is a very nice diagram which explains it. You can see here when the neutrophils coming in, causing an interstitial as well as pulmonary edema. The next one is tachypnea and tachycardia. The decreased oxygen level in the blood, it stimulates the chemoreceptors of the aortic arch, carotid, and the brain, which stimulate the cardiopulmonary center in the brain, resulting in tachypnea and tachycardia. The next one is anosmia. This is one of the most debated topic. Initially, many researchers suggested that the anosmia is due to COVID infecting the olfactory bulb. But the neuroscientists at the Harvard School of Medicine, they declined that and they said that there are no ACE2 receptors there and therefore the COVID virus cannot infect it. But instead, these COVID virus, they infect the supporting cells in the olfactory epithelium, which causes changes to the olfactory sensory neurons. But what these changes are is not fully understood. But these changes which are caused to the olfactory sensory neurons is responsible for anosmia. Okay, next slide. Okay, the next one is ageusia. Ageusia is you don't feel the taste. That is because ACE2 receptors are widely expressed in the oral cavity, particularly in the tongue. The role of ACE2 receptor in modulating the taste perception has been highlighted in many studies, analyzing the chemosensitive side of the side effects of the ACE2 inhibitors and angiotensin blockers. And also, in a paper published in the Nature magazine in August, they said that ageusia could also possibly be due to the peripheral nervous system damage. The next one is diarrhea. ACE2 receptors expressed in the esophagus, ileum, and colon is responsible for these symptoms. The next one, and the most important one, is lymphocytopenia. The picture you see here is a histological image of lymphocytopenia. You can see only 3 lymphocytes here. So an autopsy study was done in those patients who died because of the COVID-19 infection, and it was and a massive lymphocyte depth was also seen, and that was attributed to higher levels of interleukin-6. However, there are also research papers which says that decrease in T cell number was also because of the downregulation of 2 genes, that is MAP2K7 and SOS1, which are downregulated, and these genes are important for the activation and function. And therefore, both of these leads to lymphocytopenia. The next one is myalgia and arthralgia, muscle pain or bone pain. As I said before, the pulmonary inflammation leads to the systemic inflammation due to the release of interleukins and tumor necrosis factor. The inflammation developed at the bones and the skeletal muscles results in the muscle pain and arthritis. And it is clearly depicted in the diagram here. The next one is, ma'am, is my slide visible?
Yes, yes. Yes, it's visible.
Okay. The next one is a wide case study, which is done in 1,376 patients who had severe COVID infection and 2,324 patients who had non-severe COVID infection. And it was found that fever is the most common one there, followed by cough, and the least one is diarrhea. And it was also to be noted that dyspnea is seen mostly in non-severe cases. It's seen mostly in severe cases. Now, having said all this, in a nutshell, we can see the pathological basis of clinical manifestation. The first one could be the cytokine storm, the oxygen radical formation, inflammation, the hypercoagulable state of blood, or the direct damage caused by the virus. In addition to all this, it also includes the cell-mediated and humoral immunity because the alveolar macrophages engulfs these viruses through phagocytosis and they present it to the T cells, activates the B cells, producing the antibodies, which activates the cell-mediated and humoral immunity. This is a diagram which shows almost all of the pathological changes that we see associated with a COVID infection. When it comes to the lungs, the clinical feature, of course, we know is pneumonia and non-productive cough, which are among the initial symptoms. And the other one is ground glass opacity. The ground glass opacity is marked here, as you can see here in the X-ray. When it comes to the pathology, you see extensive edema, hyaline membrane formation. Hyaline membrane formation, I have shown it in the slide next, in the picture next to it. Microthrombi formation, inflammatory infiltrates, and fibrosis. When it comes to the liver, its clinical feature is elevation of almost all of the liver enzymes. Most of the liver enzymes, which includes the alkaline phosphatase, AST, ALT, and LDH. When it comes to the pathology, you see hepatomegaly, microvascular steatosis, hepatocyte degeneration, lobular focal necrosis, neutrophil infiltration, and congestion. And I would also like to add that all of these features are seen mostly in people who already have a pre-existing liver condition. Now, why is there so much of pathology associated with the liver? It could be because direct infection by direct infection by the COVID. It could be drug induced. It could be due to the oxidative stress. It could be because of the pneumonia, which causes ischemic liver injury. It could be due to the interleukins. It could be interleukins that cause the systemic inflammatory response, or it could be due to the hepatic condition, which is resulting due to the decrease to venous return due to increase in atrial pressure. The next one is kidneys. Till date, we do not have any proof which says that the COVID virus directly infects the kidneys. But however, renal damage is seen because we see increased level of blood urea and creatinine in patients infected with COVID. In the study involving 99 cases, 3% of the patients, they presented with acute renal injury. This could be due to hypoxia or shock. When you go to pathology, you see focal necrosis and vasculitis of the small vessels. And this image is taken from the Lancet magazine, which it actually summarizes how kidney could be involved. It could be due to pneumonia. There is less ventilation. It could be due to the cytokine storm, which induces endothelial injury, again, hypoperfusion. It could be due to hypercoagulable state, which leads to myocardial dysfunction and then infects the kidney, producing acute renal injury. The next is pregnancy. According to the European Journal of Medicine, there is no current report of mortality among the pregnant females who are infected with the SARS-CoV-2. However, there are complications, which include the premature rupture of the membrane, fetal distress, preeclampsia, and the potential for vertical transmission. Now, there is a case study which was conducted by Chen, which involved 9 pregnant females, and all the females had to undergo cesarean section. And cesarean section was done because there was an uncertainty of vertical transmission of the virus via vaginal delivery. Neonates. Special pediatric treatment was not necessary in case of neonates, and there so far it has been proved that there is no intrauterine fetal infections. That is because the neonates born to positive mothers, their throat swabs were tested, their amniotic fluids were tested, their cord blood samples were tested, all were tested negative. Also, however, as we know in medicine, there is always an exception. On 6th of February 2020, a neonate which was bound to a pregnant female infected with COVID was tested positive 36 hours after birth. But we do not have major clinical details of this case. The next one is blood. As I said before, there is a cytokine storm where all of these cytokines, they causes endothelial cell injury. When endothelial cell injury is caused, this exposes the collagen, the underlying collagen, that lead to coagulation. So you can see a hypercoagulable state in the blood, as well as disseminated intravascular coagulation. Also, the coagulation pathway itself is disturbed, because of which you're having elevated prothrombin time and D-dimer. Elevation in D-dimer is an indication that fibrinolysis has happened. Next one is heart. There is endothelial cell inflammation. There is increased oxidative stress. There is impaired level of nitric oxide. And All of this lead to myocyte hypertrophy and finally myocyte hypertrophy, apoptosis, interstitial fibrosis. All of this lead to heart failure. It is also to be noted that the ACE2 enzymes is overexpressed in patients who have prevalent cardiac disease. Therefore, it potentiates the virus entry into the cell. The pancreas also highly express the ACE2 receptors, and it has been reported that about 16% of the patients with COVID infection have elevated serum amylase and lipases level, and 7% of them had short pancreatic changes in the CT scan. GIT, as I said before, the esophagus, ileum, colon, all of these, they widely express the ACE2 receptors, and also viral RNA has also been detected in the saliva. And this is a summary of all the clinical symptoms that you see in the GIT: burping, heartburn, anorexia, diarrhea, bloating, etc. The next one is the most interesting one, where we get into the central nervous system. How the virus enters into the central nervous system has not been confirmed, but it could probably be due to two distinct routes. It could be hematogenic dissemination and neuronal retrograde dissemination. Hematogenic dissemination is nothing but the virus spread throughout the body via the bloodstream, after which it crosses the blood-brain barrier and enters the brain. Retrograde viral dissemination is when the virus infects a neuron in the periphery, uses its transport machinery, and then gain access to the central nervous system. However, the neuroinvasive capacity of the SARS-CoV-2 has not been confirmed. So far, we are sticking on to hematogenic dissemination. What actually happens in the central nervous system? The most common one that we see here is encephalitis, encephalopathy, stroke. It could also lead to muscular damage. And as I said before, dysgeusia and anosmia can be due to CNS damage, but it has not been confirmed yet. And when it comes to the pathology, it causes cerebral edema and degeneration of the neuron. And one more thing is that one more thing is that the CNS damage could also be due to vasculitis. The next one is a case series. A case study was done in South Italy, which involved 40 patients. The median age of the patients was 52 years, 20 were female, and 22%, that is more than 50%, had one or more coexisting medical conditions, which were hypertension in 42% of them, diabetes mellitus in 10% of them, cardiovascular disease in 20%, coronary respiratory, chronic respiratory disease in 10%, and 37% were symptomatic. And most of the symptoms included fever, dry cough, lack of appetite, and myalgia, out of which fever is the most prevalent one. In addition to that, diarrhea, anosmia, dysgeusia, nausea, rhinorrhea, and skin lesions were also seen. 60% were in home isolation, 40% were hospitalized. Hospitalized patients were older than 69 years of age. All the patients in home isolation recovered and cleared the virus. In hospitalized patients, 14 patients recovered and cleared the virus, while 2 patients died. The median time that elapsed from the first positive swab to a negative swab was 22 days for patients in home isolation and 22.5 days for hospitalized patients. With this, we conclude our seminar. And now we know the fight isn't over. We're still fighting the COVID-19 virus and the world is temporarily closed. Thank you. And these are the references that we made: the Lancet, New Journal, New England, American Journal of Medicine, the Nature magazine, DAMS classes in COVID, the European Journal of Medicine, Code articles, Harvard research papers, and Robbins Pathology 10th edition. Thank you.